So you might have noticed that I went ahead and I divided up this lecture into two parts, mainly because it is quite long. So you will see like a day 5, and this is for Friday, September 11th, part 1, and then part 2 we will actually go over on Tuesday the 15th when we have our next Zoom lecture. So it just is better to break this up into 2 parts because it gets a little deep. So yeah, so this is out of chapter 13 in pill beams, and we have enough time. So I didn't go ahead and change the whole schedule. I'm quite certain I didn't. So just kind of bump everything a day back because we have room there with those couple of catch-up days. So no worries on time here. So again, chapter 13. So today we'll be talking about oxygenation, ARDS, and then on Tuesday, our next day, we'll be talking on the 15th. Our live lecture will be talking about recruitment maneuvers and PEEP, and kind of the latter part of that chapter. All right. So talking about oxygenation, so we have different types of hypoxia, and so I kind of want to just clarify a little bit. So we have the terms hypoxia and hypoxemia. A lot of times they're kind of used interchangeably, but just kind of to differentiate between them. Hypoxia is actually defined as a reduction of oxygen in the tissues. Okay, so then hypoxemia, whenever you see emia, it means blood. That is referring to a reduction in the partial pressure of oxygen in the blood. So that's going to be represented by a decreased SaO2, a decreased SAT, and a decreased PaO2, the partial pressure of arterial in the arterial blood, the oxygen arterial, I can't speak, blood. So so that's the difference. So always think of emia, blood, the partial pressure. So your SAT and your PaO2, those are like measured values. And then, so the different types of hypoxia, we have hypoxia, so we can actually combine the two of them. And that's something that we'll find like when we're at elevation, the partial pressure of oxygen is less because the barometric pressure is lower, and then hypoventilation can lead to hypoxemic hypoxia. Anemic hypoxia would be a low red blood cell count, low hemoglobin. Circulatory hypoxia would be due to reduced cardiac output, which would lead to low tissue perfusion. And then histotoxic hypoxia would be related to cyanide poisoning. All right, so then just your different levels of hypoxemia, and most of you, not all of you, but most of you that I saw kind of define that when you were looking at your blood gas analysis. I didn't take off points for not really addressing that, but that's kind of what I was looking for. So depending on what the PaO2 is, and they were low, they were hypoxemic, what degree? Was it mild hypoxemia? If it was a PaO2 of between 60 and 79, then it's considered mild. Between 40 and 59, then is considered moderate, and then less than 40 would be considered severe. So in the future, just know that that's kind of what is needed, and I'll make sure that I clarify that the next time. All right, so oxygenation. So basically, we really would like to figure out why are we hypoxic? Why is there a low oxygen level? What's going on? So obviously with hypoventilation causing hypoxemia, if we increase our minute ventilation, we're hoping to increase our oxygenation, as well as if we increase the FiO2. So those are things that would hopefully improve. However, keeping in mind, so in hypoxemia that is caused by a decrease in the VQ ratio or for hypoventilation is more responsive than to the increased FiO2 than hypoxemia that's caused by a diffusion defect. Okay, and that one is going to, a diffusion defect or a shunt is going to respond better to an increase in PEEP. Okay, so if you're hypoxemic and the reason is a decreased VQ ratio, is caused by a diffusion defect or a shunt, you're going to respond better to an increase in PEEP rather than just giving them more O's. Blood products, obviously, for anemic patients. Fluids, if it's a circulatory issue. Fluids and other pharmacologic interventions, such as drugs that would increase the ventricular contractility or would decrease your vascular resistance. With a cyanide, you would give the antidote, which is hydroxycobalamin. Now, our old friend here, the different equation with your known and your desired. So make sure that you're familiar with this, and we'll be going over these similar equations in lab on Friday for today's class time. I think we go over this one, but I know we for sure go over the PaCO2. If not, we'll be going over it again down the road. But so, for example, if you had a PaO2 that was 50, so if you're known, so on your left side of your equation there, if you had, so looking at the top equation, if you had 50 for your known PaO2 over 40, okay, and your desired PaO2 would be 75, so you would go ahead and you would cross multiply. You would take 75 times 40, and then you would divide that number by 50. And so remember that lovely cross multiplication, solving for x, and that would give you an FiO2 of desired of being 60%. So a lot of times, we also go by, we get a blood gas, but we also are looking to see for trends on the pulse oximeter, and a lot of times we'll titrate to that too. But sometimes they'll want another gas just to make sure. All right, so mean airway pressure. Mean airway pressure is basically the average pressure across the respiratory cycle. And different things that there's many different things actually that you do that can change the mean airway pressure. Your changes in your peak inspiratory pressure, your tidal volume, alter your mean airway pressure. Your flow can alter your mean airway pressure because that's going to mess with your I time. So those are all definitely related to a direct relationship to increasing your oxygenation. So you look at your peak airway pressure. Remember, your PIP is what's recruiting the previously closed alveoli, and then the PEEP is what keeps them open. Okay, so you have both of those kind of working for you. And the different types of ventilation where we really are focusing on that mean airway pressure is pretty much high frequency oscillatory ventilation. And let's hope that when I don't even know if we will though, because that's probably going to be about a month away or a few weeks away where we do that. Darn it, we'll probably not be able to get up to Good Sam's just with all the COVID stuff. We'll kind of see what's going on. But Marty does a really nice presentation for us with the oscillator, because they have an oscillator up there. But that's pretty much the whole purpose of the oscillator, is to maintain mean airway pressure. And that's the principle of how it works. So you're using the oscillator not so much to ventilate somebody, but you're using it to oxygenate somebody. So, and then APRV is another method or a mode of ventilation that you would consider for oxygenation, and also getting that 1-to-1 and even reverse true APRV. Actually, it's kind of funny because they said inverse ratio, but I guess the difference with APRV is it needs to be at least considered a 4-to-1, which is an inverse ratio. But the thing that's different about APRV, and we'll talk about it, is that you have that valve open where you can then actually spontaneously breathe in between the pressure levels. So it's not like they're locked out. So that's what makes a difference, and that's what also helps get rid of the CO2. But we'll talk more about that here in a few weeks. So mean area pressure, when you think mean area pressure, you should just immediately think oxygenation. Okay, I want to increase my mean area pressure because I need to improve my oxygenation. And PEEP also would increase your mean area pressure. Okay, so factors that again increase mean airway pressure. So not having any spontaneous ventilation. I just mentioned spontaneous ventilation with APRV helps them get rid of the CO2. But so, you know, really keeping that, increasing that positive pressure, increasing the duration of inspiration, decreasing the duration of expiration, hence kind of that reverse I to E, where you have a longer I time and a shorter E time. I mean, the high frequency oscillatory ventilation, it's based on hertz, and 1 hertz equals 60 breaths per minute. So it basically kind of sounds like, and you're going to laugh because I'm going to do this on the little microphone thing here, but it's like kind of sounds like a little jackhammer. It's just giving little quick puffs of air, and there's hardly any time of real minimal time of any exhalation. Your waveform, so your flows, increasing your PEEP level, you know, you're decreasing your compliance because there's not that much air moving in and out. You're really maintaining that pressure into the lungs. So now we're going to talk about ARDS, and that is one thing where we will definitely use these different modes of ventilation to hopefully increase the oxygenation, increase the mean airway pressure on these types of patients that develop ARDS. So ARDS is a pulmonary disorder, but it ends up being kind of a multi-organ failure disorder as it continues to cascade with its events. Can't get through a lecture without a bark. So it also is, we have developed severe hypoxemia with these patients and shunting. It's basically a syndrome of severe lung injury, and it has an acute onset. The PF ratio that you talk about is kind of telling us the degree of lung injury, and different strategies that we use, different modes of ventilation, continue to be controversial on really what works best. So it's kind of like one of those little experimental things with each patient on how they respond and what else is all going on with them. So basically, if you have a PF ratio between 200 and 300, that is considered mild, with a 27% mortality. If you go down from 1 to 200 on your PF ratio, then your mortality bumps up to 32%, and it is considered severe if it's less than 100, with a mortality of 45%. So there's some different definitions that have been floating around for the last several years. The old definition by the American European Consensus Conference that was back in '94 basically defined it as acute with a PF ratio of less than 200, bilateral infiltrates, and pulmonary capillary wedge pressure of greater than 18. So this basically kind of led to the protective lung ventilation. So we kind of started doing these different practice bundles. So that was kind of part of the beginning. This gave kind of more of a vague definition. The acute part was poorly defined because it really didn't define like how many weeks or days that would make it acute. The PFs can be manipulated by changing the PEEP. Chest x-rays were unreliable. I don't think they really used them consistently. The pulmonary artery catheter was rarely used because it could also be elevated for other than heart failure. It could be elevated for reasons other than heart failure, and it's an invasive catheter. We really don't see them used as much, but they're definitely out there. You will see them hopefully out there, but and then the term acute lung injury was kind of used inconsistently. So then in 2013 the Berlin definition was kind of established as ARDS being an acute diffuse inflammatory lung injury leading to increased pulmonary vascular permeability, increased lung weight, and loss of aerated tissues, with hypoxemia and bilateral radiographic opacities associated with increased venous admixture, increased physiologic dead space, and decrease in compliance. So that is the Berlin definition verbatim there. And we'll talk a little bit more about all these parts of it here coming up. So the acute is basically saying that its onset is within a week or less. The bilateral opacities are consistent with pulmonary edema, must be present, and they have to be detected on either a CT or an X-ray. Your PF ratio needs to be less than 300 with a minimum of 5 of PEEP or CPAP, and must not be fully explained by cardiac failure or fluid overload. So that can't be the reason. So they need to do an echo to make sure there's no other clear causes such as trauma or sepsis, but those things can also lead to ARDS. So there also were issues with this definition because the ability to predict the mortality is still poor. There's these 4 different variables for severe ARDS were assessed, but do not really have a predictive value per se. So, the radiographic severity, that can be somewhat like a subjective, I guess. Depending on who is reading it. The compliance of being less than 40, that's definitely a hard, fast number. PEEP of greater than 10, exhaled minute volume of greater than 10 liters per minute. Does not include underlying etiology and lacked a direct lung injury measurement. One thing for sure, and this is a lot with many cases, is you are going to see patients that if they're on vasopressors, if they're on any type of vasopressors at the time of ARDS diagnosis, they definitely have a higher mortality rate, regardless of whatever their PF ratio is. And that actually kind of goes for a lot of patients with a lot of different things going on. If you end up having to be on vasopressors for a long period of time, your mortality rate definitely is going to be higher. Okay, so these patients present with persistent tachypnea. They're struggling to breathe. They have hypoxemia. Their x-rays look like crap, or their CT, they kind of get this whited out appearance, and their lung compliance starts to go down the tubes. They become very stiff. So in the pathophysiology, there's inflammation that is found in the pulmonary capillary endothelium and the alveolar endothelium. And what happens then, results in increased permeability of these tissue layers, and that's how the lung really gets kind of heavy and wet. So the injury to the lung parenchyma then leads to this leaking of protein-rich plasma out of the capillaries into the interstitial spaces and then into the alveolar space. And that's what you can see then on the CT. So that fluid is gravity dependent, and it kind of looks like this ground glass opacification, or they may refer to it as a whiteout on the x-ray. It kind of looks like I always think of like if you were to take like a cotton ball and kind of like pull it apart, or like the filling from a pillow or something, like the little foam kind of, not foam, not the hard stuff, but the little fluffy stuff, kind of like that, and kind of look through it. It's just really like that. So again, the inflammation produced abnormal thickening then of the alveolar epithelium and the alveolar space, and adds with inflammatory cells, there's cellular debris and edema. And I'm going to talk more about that here on the next several slides. So the opacification then is associated with that inflammatory process. So it's kind of like, swelling and leaky. The inflammation again produces that abnormal thickening of the alveolar epithelium. And so the inflammation produces this abnormal thickening of the alveolar epithelium. I've already said that twice now, but the alveolar space then is filled with the inflammatory cells, the cellular debris, and edema. So this leaves the acini, the little tiny lung sacs, with low lung volumes and sometimes even no volume, and the villi become atelectatic. So what happens is this is all this involves then capillary damage. Basically your ARDS, well, I'll go ahead and kind of read through this, but then I've got some other notes here that I have on the side. Let's kind of explain between this slide and the next slide. But so we have this platelet aggregation that happens. So the inflammatory process basically with ARDS involves a complex interaction between the platelets, the leukocytes, the mononuclear cells, the macrophages, and the epithelial cells. So we have the activated neutrophils, the alveolar capillary damage happens, this increased permeability, we develop vasoconstriction, a VQ mismatch, and then the alveolar damage. So there's the type 2 cells end up getting damaged, so the surfactant production is decreased, which then leads to further decrease in your compliance and atelectasis. And I'm going to kind of mention this now, and I know it comes up again in a couple more slides too, but so the ARDS really can be divided into two different phases. We have the first phase is your acute exudative phase, which is characterized by the inflammation and the alveolar filling. And then your second phase is your subacute phase, which is where the fibrosing and the alveolitis occurs. So the lungs even become more stiff. The leaky capillaries actually then lead to multi-organ failure. So it becomes like a kind of a cascade of events. So again, I'm going to repeat this. The inflammation process associated with ARDS involves a complex interaction then between your platelets, your leukocytes, your mononuclear cells, your macrophages, and your epithelial cells. So there's also chemicals that mediate the inflammatory process. So some of those are the nitric oxide, the leukotrienes, the cytokines, the proteases, your plaque activating factor, these cationic proteins, interleukins, and tumor necrosis factor. So these all lead to multi-organ failure. So ARDS should really be viewed as a systemic syndrome, not really just a pulmonary problem. So what ends up happening is, these patients end up developing trouble with their blood pressure, and then one of the first organs to be hit with a low blood pressure is kidneys, your kidneys, and then if your kidneys start failing, then your heart starts to fail, and so everything just kind of goes to crap. One of the things that you may hear is if they ever say that a patient's on a renal dose of dopamine. A renal dose of dopamine is just a low dose of dopamine to actually make sure that the kidneys can be perfused. So we want to make sure that kidneys have a urine output of at least 30 mils per hour. If they don't put out 30 cc's in an hour, then you definitely can risk going into renal failure and needing dialysis. So just a little trivia there. So this picture here, this is basically looking at all the different cells and kind of what's happening. On the left side you can see a normal alveolus, and on the right side you're looking at acute lung injury and talking about all the different processes that are going on in those different reactive oxygen species that we were just kind of talking about on the previous slide. So basically during ARDS, leaking occurs into the interstitial space and into the alveolus. And here's just another slide, just a little bit different. Pretty much is saying the same thing, but just another view, different labeling, but it's covering all the same stuff. This one's a little bit slightly more in detail. So in ARDS, again, the inflammation of the pulmonary capillary endothelium and alveolar endothelium results in increased permeability of these tissue layers. Injury to the lung parenchyma ultimately leads to leaking of protein-rich plasma out of the capillary, first into the interstitial space and then into the alveolar space. So that's what's going on. You get leaky lungs, which leads to stiff lungs. So we have reduced volumes, a reduction, a decrease in your FRC. Regional differences and varying amounts of inflammation are present. So, some patients do better proning or on certain sides. Parenchymal injury may also affect the airways, the bronchioles and the alveolar ducts, and then the small airways become narrow and they collapse with reduced ventilation volume of some areas. So ARDS can be developed by different mechanisms. So we're going to look at this as either it being direct or primary. So direct, primary kind of being the same thing, or indirect, secondary. So in this one we're going to be talking direct or primary pulmonary. So direct, where lungs are mostly consolidated, and the causes can be viral, bacterial, fungal pneumonia. Gastric aspiration is probably your most common. So aspiration pneumonia or pneumonitis, a patient that might have been found down and they have, they definitely aspirated a lot, they're at a risk for ARDS. Toxic inhalation of these different chemicals, near drowning, and lung contusions. And lung contusions also are a result of like motor vehicle accidents or motorcycle accidents or falls or any kind of trauma. So consolidation, so when it says it's direct that the lungs are mostly consolidated, consolidation is a homogeneous increase in the lung density that obscures the bronchovascular margins. That's kind of how it's defined. So your secondary risk factors, so this is generally indirect. Alveolar collapse is predominant versus consolidation. And this can be from sepsis, chemical or heat burn injury, prolonged systemic hypotension and shock, multiple trauma, pancreatitis, drug effects such as thiazides, which is a diuretic, and salicylates, sickle cell crisis, multiple drug transfusions, and hepatic failure. So all of the risk factors share a commonality to initiate the systemic inflammatory reaction that really is what leads to the diffuse lung injury. Non-pulmonary ARDS is associated with an acute, and basically I'm kind of saying the same thing, and this is where some of these other notes came from. So your non-pulmonary ARDS is associated with acute systemic inflammatory process. Again, your acute sepsis and acute pancreatitis. So it's just interesting how all these different problems with patients, when they come in with, they end up developing ARDS. Again, your primary is your direct, which is where the lungs are mostly consolidated, and your secondary is indirect, where you have alveolar collapse is predominant. So lung recruitment maneuvers are more likely to improve oxygenation and compliance in secondary ARDS. So definitely highlight that. Sorry, I'm trying to get the dog out of here before she howls again. And then here was I was mentioning before about the two different phases. So you have this acute exudated phase, inflammation and alveolar filling, and then the subacute phase, the fibrosing alveolitis. So, so how it kind of presents itself is within the first week, the normal lungs appear in the non-dependent areas. And so that's kind of what we're looking at here. And the ground glass appearance then in your middle area, and then consolidation appears in a dependent area. So you're kind of reading this in from left to right on your images. So first week, the normal lung appears in non-dependent areas. So non-dependent would be like the anterior or the top part, not the posterior. Ground glass appearance in the middle area of the lung, and then consolidation in that bottom part on the furthest, the picture on the right side. Okay, so the weight of the heart and the abdominal pressure may actually increase the amount of atelectasis in the dependent areas near the diaphragm. So your capillary osmotic pressure, that's what the COP stands for, tends to pull fluid out of the alveoli in the interstitial space into the pulmonary circulation. So the amount of edema present depends on the pressure gradient between the space inside the pulmonary microvasculature and the space around the vessels. So again, the amount of edema present depends on the pressure gradient between the space inside the pulmonary microvasculature and the space around the vessels. And this is coming right from your Pilbeam's chapter 13. So even when pulmonary blood pressure is normal, edema still can form. So this is a result of expanded lung tissue during the application of PEEP, or high lung volumes, pulling on the corner vessels in the adjacent tissue, which then creates a negative pressure gradient from inside the corner vessels to the outside of the vessels. So it's just kind of the shift of the pressures here. So if fluid management is aggressive in ARDS pathophysiology, the pressure in the vasculature can increase. So the pulmonary capillaries can leak more and lead to a production of increased biochemical mediators known as procollagens and fibronectin. So it's really important to, especially for nursing, but it definitely affects our ability to oxygenate and ventilate these patients. They really try to keep them a little bit on the drier side, I guess, as far as fluid management, because they really want to reduce that extravascular lung fluid, because the wetter we are, the harder we are to oxygenate. So it's really a fluid management. It has to be a real careful balance, and at the same time they're also trying to maintain the blood pressure. So you'd like to be able to give fluid, give more volume to maintain blood pressure, but at the same time that's going to maybe lead to more a heavier wet lung. And then also, but then you also have the issues of going on vasopressors and all the harmful effects from being on those for a while and trying to get patients off of those. So there's no real current evidence that a low vascular volume approach, though, does reduce morbidity and mortality. Some practitioners tend to, with higher volumes, to avoid hypoperfusion to the lungs, to the tissues and organs. I mean, it really depends on what docs are on and what how they want to manage these patients, because keeping them too dry can lead to hypovolemia, and then then you're having trouble with renal perfusion and that kind of stuff. So again, the cytokines and then other inflammatory thrombotic mediators are released into the bloodstream from the lung, and then these mediators with other body organs can aid in multiple organ failure. So again, it's not just a lung problem, it's really a systemic problem. So a couple of different things here. This is talking about in the 1980s there was a study where they looked at CT scans, and they definitely concluded that the injury in the ARDS is diffuse. The distribution of fluid and atelectasis were influenced definitely by gravity, so the involved areas were dependent. In the 1980s, that's when I first became an RT, we used the larger tidal volumes of 10 to 15 mils. Large volumes entered then the already opened areas, unfortunately, independently, and so the larger volumes entered the already opened areas independently. Almost no lung volumes, so it basically overdistended the areas that were already open. So that really didn't help us at all. So it resulted in overdistension injury to independent lung regions, and caused low compliance to appear, made the compliance to appear low. Sorry, getting to the end of my day here recording this. All right, so also previously the trend was to use pressure control ventilation. So then that's when we limited our pressure. That's when they decided that PEEP can improve ARDS outcomes. So upping the PEEP from 5 to 15 definitely made the lungs have better aeration on CT scans. Oh, something I wanted to add about that last slide, that the gentleman with the Gattiani physician, he used the term baby lung because a relatively small area of the lung actually received most of the volume, causing overdistension. So you're basically, ventilating the area of the lung that really didn't need to be ventilated because it was already open. All right, moving on. I think I might have accidentally forgot to talk about the slide before this one. And unfortunately, I can't go back. It just kind of like messes up the whole thing. It like just messes it up. So I'll go ahead and talk about the slide. I believe that was before this one because I accidentally clicked. So greater densities on CT occur then in those dependent areas in spine, because it's associated with the increased pleural pressure from sternum to spine. The increase in pleural pressure causes a decreasing the transpulmonary pressure, which is the alveolar pressure minus the pleural pressure, okay, which is the distending forces of the lungs. Therefore, the dependent areas would have more atelectasis than non-dependent areas, and that makes sense because the weight on the dependent areas are going to have more atelectasis. And with ARDS, the lung weight due to the inflammation and edema is already an issue. It is double to triple of that of a normal healthy lung. So the increased mass creates gas being squeezed out of the lung units in these dependent zones. Compression can be caused by two factors. We have the interstitial edema can lead to lung collapse, and then the alveoli themselves may be filled with edema. So that can definitely be a problem. That's why proning these patients and moving them around, putting them, prone for I don't know, it depends. Sometimes it's 6 hours, 8 hours, and they flip them again, and then they kind of go back and forth. I think of them like being like a little rotisserie chicken, where they're kind of like, turned over, kind of. We actually used to have roto beds that kind of did that. They just kind of slowly turned them. I mean, you could kind of see the movement, but it was pretty slow. Like they would go way over to their left side. And they were actually great beds to use back when we did chest PT, because you could actually kind of manually turn them too, where they could be on their one side, and then part of the side rail kind of piece kind of came off, and you could access them for whatever you needed to do. But back when we did like kind of a little bit more manual percussion, or even with a little pneumatic percussor, and then we flip them over and then do the other side. And then plus it just kind of really helped oxygenate them a little bit better. Also the idea too of moving them around kind of without actually physically moving them, but pressure points basically, again for gravity, for bed sores and that. But you don't really see those roto beds anymore. First of all, they were very expensive because they would rent them generally for a patient, and then there was also some trouble with getting them, and they could even prone with them too, was to get them flipped back right where you needed them to be. Like in a case, I heard of a few things where they couldn't get them in the right position, like if somebody coded or something. So that's not good. All right, so adding PEEP then helps to counteract these high pressures from the added lung weight. You should choose a PEEP greater than or equal to. That really should be greater than or equal to. It's hard to do another equal sign with the line. Choose a PEEP greater than or equal to the gravitational pressure of the lung weight to maintain an open dependent region of the lung. Okay. Less PEEP is required to keep the lung open in the middle area. No PEEP then obviously would be required in the non-dependent region, because the lung parenchyma there is not compressed. So over-distending the non-dependent areas can actually still be a potential risk of PEEP, because it goes wherever it needs to go, and it's probably going to be in the like the path of least resistance, just like PIP would be. Lastly, it's kind of interesting, the long-term follow-up on these patients with the ARDS, it really definitely affects them for a long time. If they survive, they have distinct changes, forever on their CT scans. They have both obstructive and restrictive patterns are seen in long-term follow-up studies of their pulmonary function tests. And there's also a lot of neuropsychological dysfunction. These patients can have cognitive and affective impairments. They also can have like PTSD from their experience in the ICU. The ICU psychosis that develops, the medications, the fact that they're always being messed with. They have no really sense of day or night. They can develop, and this is, afterwards, after they're, well and home, they can have trouble with hallucinations, paranoia, they can have depressed personality, they can develop personality changes. So sometimes for these folks, it's always like, we have to kind of look at, how are we leaving these people? Do they really, go back to a normal, they probably have a new normal, basically. They're probably not going to be the way they used to be. And so that is it for today. So we will do part 2 on Tuesday.